Hello, this is Dr. Sameen Afzal Junejo from Afzal Eye Clinic, Hyderabad in Pakistan. Friends, today I will show you a video, the case performed by me with a single-headed Phaco IOL surgery technique. As per routine part of the surgical procedure, closed chamber anti-clockwise capsular access is performed with the help of a needle cystotome. .27 gauge insulin syringe needle cystotome is used, and the approach is through surgical limbus. A round rhexis was performed in presence of a dilated pupil. My approach is always through the surgical limbus. And now, as a second component of the procedure, two-step corneal incision is given with the help of a diamond knife through surgical limbus. And as you know that the surgical limbus is a bit away posterior to the anatomical limbus or the gray line of the cornea. In this case, OVD disperser was used to deepen the anterior chamber just to facilitate the formation of a side port with the help of a 15-degree 1.4 millimeter diamond knife, and the incision was again two-step incision. In this case, the second side port was not made because the patient did not have much astigmatism against the rule, and the astigmatism against the rule was less than 1. Hydrodissection is performed with the help of a ringolect, and after doing the hydrodissection, the viscoelastic was installed onto the anterior surface of the cornea to prevent dehydration of the cornea during the surgery, and also it aids to magnify the surgical procedure inside structures. The lens and the details of the anterior chamber. A Phaco tip is introduced through the full thickness corneal incision. A trench is made in between, and the nucleus is held by means of a equator, and linear Phaco emulsification is carried out through a minimum phaco energy. The phaco chopper in this case is not used because the nucleus is soft and mobile, and there is no any need of breaking the nucleus into fragments by means of a phaco chopper. The nucleus is engaged at the phaco tip under high vacuum of 550 and the flow rate of 38. The ultrasonic power in this case is 40. Nucleus is removed very comfortably without using any chopper through the side port. And now viscoelastic solution will be injected into the anterior chamber to complete irrigation and aspiration of the cortical matter with the help of a two-way irrigation and aspiration Simcoe cannula. The use of viscoelastic solution at this step is also quite helpful, preventing the posterior capsular rent. And lubricates the epinucleus and cortical matter. The cortex at 12 o'clock is dislodged and all around 360 degrees with the help of a Simcoe cannula. Comfortable and controlled irrigation and aspiration is performed and completed by two-way Simcoe cannula. Nucleus, the cortical matter is removed comfortably and completely. OVD dispersive is again injected for the third time to deepen the anterior chamber and form the bag for foldable intraocular lens implantation. During the whole surgery, we have not used the side chopper. So this is a single-handed phaco emulsification and IOL implantation procedure. There are many advantages of single-headed phaco IOL operation. One of the most important and common advantage is that it prevents the phaco energy to spread up and damage the corneal endothelium when the phaco power hits the metallic chopper. One piece foldable acrylic intraocular lens is now being placed exactly into the bag. This is a very good intraocular lens with a very powerful haptic memory, and the dialing in this case, using this IOL is minimum. The positioning of the intraocular lens, the position is central in the bag. Slight manipulation is being done with Simcoe cannula to remove or irrigate the trapped viscoelastic solution behind the nucleus anterior to the posterior capsule. Removal of the viscoelastic material is important at the end of the surgical procedure in order to avoid postoperative transient rise of intraocular pressure and the cellular reaction sometimes happens. Corneal surface is cleaned, washed with the Ringolect, and now a cocktail intracameral is given behind the iris to induce meiosis. A little bit antibiotic and decadron is also mixed with the pilocarpine. Pupil is getting myosed and providing a very good support to the newly implanted intraocular lens anteriorly. So the pupil which constricts provides anterior support to the intraocular lens which is implanted in the posterior chamber exactly into the bag. I usually position the IOL with the haptics vertical because it doesn't change the position or cannot give rise to any sort of oblique astigmatism.